Welcome everybody to our webinar tonight. So we are going to start now. I see that we have about 27 attendees, and I'm sure that more will log on as they get to us. I'm Dr. Lena Nido. I'm the GP liaison at the Eye Hospital. I usually work there on Thursdays. I'm just going to give you a few little bits of information, and then we'll move on to the main presentation. And firstly, I'd like to acknowledge the people of the Kulin Nations who are the traditional custodians of this land that we meet on today. I'd also like to pay my respects to elders past, present and emerging, and to any Aboriginal people here today. I'd also like to acknowledge the Collier Charitable Fund, who has generously donated funds that help support our GP education program, and also our speakers, Dr. Jwu Jin Khong and Dr. Rod O'Day, and the Northwest Melbourne PHN, who partner with us to bring you these presentations. We couldn't do it without them, without any of them. Feel free to ask questions as we go. Now, all of the audience are muted, so you will need to type questions into the question box. If you look at your go-to webinar control panel, about 1, 2, 3, 4, 5, 6 arrows down is an arrow called or a triangle with questions. You click on that and then you can type questions into there. I will be monitoring that and moderating that throughout the session. If your question's very relevant to the slides or what's being discussed, I will interrupt the speaker. But if not, I will leave some of the questions to the end. If you have any technical problems, could you please type them into the chat section, which is the lowest triangle. And Madeline from the Northwest Melbourne PHN is in the background, and she can help assist you with any technical issues. We are recording this event, so we will let you know when it's available from our website afterwards. Evaluation forms will be emailed to you at the close of the webinar, so please complete them as soon as possible, because we really do value that feedback, and we need it, I think, for the RACG points and to plan our future events. This agenda is slightly out of date. Dr. JJ Khong is going to be presenting second as she's delayed, so Dr. Roderick O'Day is going to start. Just a very, very brief update about the hospital website for those of you who aren't familiar. That's the address there. If you go to health professionals for GPs, that's where most of the GP information is. I'll just go back there. And we do have COVID-19 hospital updates, so you can have a look on there for the latest updates. And importantly, we do have referral guidelines, so please look at these when you're referring to hospital services. We do have referral thresholds, so some conditions need to meet those thresholds before referrals will be accepted, and so some conditions are not accepted. Additionally, the Department of Human Services has introduced statewide referral criteria, and this year they will be introducing the ophthalmology referral criteria. So our referral guidelines do encompass all of that, but also if you need assistance, health pathways, so they're clear, consistent criteria, health pathways. Melbourne, for those in the Melbourne area, are there to assist you to refer and manage conditions that do have statewide referral criteria, and there's actually a list of some of the ophthalmology conditions that do have statewide referral criteria, and gives you assistance on how to manage those things and then what the appropriate referral pathways are. And you can access health pathways by contacting your local PHN. So if you're not in the Northwest Melbourne or the Eastern Melbourne PHN, then you can go to that website there to find out. I won't go through all of the learning objectives. I'm sure each speaker will let you know what their learning objectives are going to be, but I think it's really interesting topics that we haven't really covered some of in our previous events. So firstly, I'd like to introduce Dr. Rod O'Day. He's a consultant ophthalmologist, ophthalmic surgeon at the Royal Victorian Eye and Ear Hospital, the Royal Children's Hospital and University Hospital Geelong, and an honorary researcher at the Centre for Eye Research Australia. He specialises in ocular oncology, medical retina, and general ophthalmology. His research interest is ocular oncology, in particular best practice management of choroidal nevi, advances in management of retinoblastoma, and new diagnostic tools for intraocular lymphoma. So he's going to share some of his insights today. I'm going to hand over to Rod now. So there you go,
Thanks,
Rod,
Lena.
your screen is sharing. Thank you.
So all the things I do are very, very rare, and I've tried to make this presentation as relevant as possible to general practitioners, and to help sort of avoid the, to pick those rare and life-threatening things, and then also to talk about some of the complications of the newer anti-cancer agents that we're seeing, just as something to be aware of. So obviously the big one is in children is retinoblastoma. So if you have a patient with a white pupil or a squint, how to assess them, and also which patients need referral and what retinoblastoma is. That's one of the learning objectives. The next is talking about adult tumours. So in terms of tumours that there are, so the most common pediatric tumour is retinoblastoma, and the most common adult one is choroidal or uveal melanoma. So that's at the back of the eye. But both of those are very, very rare. So retinoblastoma there's about 10 new cases a year in Victoria. Choroidal melanomas closer to 75 to 100, but so not very much of it. But choroidal melanoma and the surveillance program, we often have use it as the physicians looking after us with these patients will be organising their surveillance program to detect metastasis, and that's going to become increasingly important as new agents come online to help treat metastatic disease. There hasn't previously been any agents that prolonged life, but there are some new ones which are coming out. So it's very exciting to be working in this area, but also there are going to be implications for you as the physicians who are looking after them in the community. And then finally, as I mentioned, just talking about a couple of the novel anti-cancer therapies, and in particular, I focused on, I also am a retinal specialist, and I'm focused on some of the rare complications that happen in the retina, and I'll talk briefly about the common ones that you have with with some of the other agents. So in terms of retinoblastoma, I'll just start with the key messages, which are these ones that I've listed here. I've quite an algorithmic mind, and I like to make things as simple as possible. And most of ocular oncology is very simple. The thing is, if you see a child under the age of about 4 or 5 with a white pupillary reflex or a squint, so a turn either in or out of the eye, then they need to be seen urgently by an ophthalmologist. So that's very easy. The other thing is retinoblastoma, as I'm sure you're aware, is the genetics of this condition are very important. It was one of the first conditions that was found to have a tumor suppressant gene, and the two hit hypothesis came from studying this condition. So the retinoblastoma gene is on chromosome 13, and basically, if there's any family history of retinoblastoma, there's significant implications, and it's either there's a range of implications. So there's either it is a somatic mutation, so it's only in the cells in the retina, or it's a germline mutation, and so it's in the cells and there's a mutation in every cell in the body, or it's in between. And so really, if you have a patient with retinoblastoma, or there's a history of retinoblastoma, it should give you some alarm bells of things you just want to check when you see those patients.
Sorry, excuse me, Rod. Rod, may I interrupt you just to have a question of my own? In terms of children with squint, I always forget, you know, obviously none of them start out with eyes pointing in the right direction, and I can never remember at what age are we supposed to be concerned and referring them from the youngest?
The key is whether it's intermittent or permanent. If you've got a kid with an intermittent squint, you know, the typical thing is, parents can notice that there's a bit of a turn at some point in the day when they see their newborn child. And you're absolutely right that it takes a while for vision to develop to the point where they can hold fixation. But they should be relatively straight most of the time. If you have a child, a newborn child with with a turn that's there all the time, then that's a red flag. And then if you have a child that previously had straight eyes and then develops an intermittent squint, then again that's a concern. I suppose they're how I think about it.
That's great. Yeah, that's great. Thank you. Please go on.
So RB is it's the most common tumour in childhood, intraocular tumour, and it's 1 in 17,000 live births. So there were, I think a couple of years ago when it was collected in Australia, there were about 20 in Australia. It is almost certainly not going to present in a child who's over 5 years old. So, and the typical age for someone without a family history tends to be 2 to 3 to 4. So rare, very rare in a newborn unless there's a family history. And if we see a child without a family history and it's in the first year of life, that's pretty rare. But certainly possible. And typically, as I say, it's after 5 years, the retina. So the retinoblastoma is a tumor of the retinal cells, and by the age of 5, most of those have fully matured. So very unlikely to form them after that period of time. These are the presenting symptoms, and that's why I mentioned leukocoria, just white pupillary reflex, and then squint. These other ones, so orbital inflammatory change is basically the eye looks like orbital cellulitis. By that point, you know, the eye's red and it's swollen and the lid's puffy. These patients, I think everyone can recognise they need to be seen urgently. And then poor vision, that's a bit trickier to pick up. In terms of the one thing with leukocoria, so this is the differential when we have a look at leukocoria. It depends a bit on the age. So retinoblastoma is young children less than 5 years old. Cataract often is at birth, it's noticed. And then there are a couple of other these are retinal vascular disorders. Persistent fetal vasculature is there from birth and typically associated with other malformations. Coat disease typically occurs in 7 or 8 year old boys. Then there's retinopathy of prematurity, which we're going to know about because they're premature and they will have been screened in hospitals, and then some inflammatory conditions which are rare. So this is just some different photographs that I have of of leukocoria and what the different things are. So the one that we see a lot of is this second one here of that little boy, and the parents will come in and show you a photograph of, and there's been a flash, and it'll look like there is a white reflex, and it's just because of the angle of the eye with the lens. So that if you have a child like that, we often are referred these patients, and there's absolutely nothing wrong with that. I suppose if it's reproducible that happens, then that's concerning. But often these are not actually anything to be concerned of, and it's just because of taking the photograph. This one up here is, I think this is a cataract. This one is actually a retinoblastoma. And this one down the bottom is Coates disease with a total, that's all the retina has been pushed all the way forward. So you can see that they can all look quite similar, completely benign through to life-threatening, sight-threatening, or complete loss of sight, and something that can be done to improve the vision in terms of cataract. The child can have cataract surgery. So I suppose the take home would be from looking at these different causes of leukocoria is, if you see it, it doesn't really matter what the diagnosis is. All of these need to be seen by a paediatric ophthalmologist. In terms of referral pathways in Victoria, there are a number of them, either to your local hospital, depending on where you are. The Eye and Ear is always a good resource. They're very strong ophthalmology departments in a number of the major general hospitals. Where I work in Geelong, there's a very good department. There's a very good one in Monash, Northern. So it doesn't all have to come to the Eye and Ear. The Children's Hospital also has a fantastic eye department, and it is a great place to refer these patients, as well as your local ophthalmologists. In terms of urgency,
Rod, sorry, I might interrupt there, because we always get questions about the sort of age of children that should be referred to the Eye and Ear as compared to the Children's Hospital. And do you have any guidance for the GPs as to, are there limitations to the age of children what we can accept?
Yeah. I think if anyone turns up to the hospital, they will be seen. But the key is whether we're going to be able to examine them. If a child is less than about 2 or 3 and can't be reasoned with, then they're often better seen at the Children's, and that's because at the Children's there are ED doctors and examinations rooms where they can be given nitrous, so that we can actually examine the patients, the children, well in the emergency department. So I think that's a rough rule of thumb. So I've got a 15-month-old that you might be hearing in the background here. I would be sending her to the to the Children's, because I know that no one will be able to get anywhere near her eye. So that's how I'd assess it. Is what do you think the chance of someone being able to examine the eye? And there's no, some 3-year-olds or some 2-year-olds are amazing, and that'd be absolutely fine. But that would be my recommendation. Hope that's reasonably clear.
I've got you back. Sorry, I lost you for a moment. I think it was my internet connection. So hopefully everyone else heard what you had to say.
Well, summary is if you think the child is old enough that they'll be able to be examined by someone, and basically to be examined, you can see when you see the child, if they can look to the left and you can ask them to follow instructions. If they can't follow instructions, then probably best to go to the kids where they can be examined under nitrous.
Absolutely. Thank you.
In terms of other things for this, I think that's about all.
You were, sorry, I interrupted you before when you were going to talk about urgency of referral.
Oh yeah, urgency of referral is urgent. So if you see a kid with leukocoria, it's not, you know, it's not middle of the night stuff, but it's within the next day or two. So if you see them in the morning, they should go to, you know, they should, if you can't get them in to see an ophthalmologist in the next day or two, then I'll be sending them to the local hospital, because you really want to establish a diagnosis. If it's retinoblastoma, we would like to start treatment within about a week, as the doubling time for these tumours is reasonably quick. Obviously, this is why it's an issue. In Australia, we have incredible, retinoblastoma is a real oncology success story. It used to be fatal. Then it stopped being fatal in the 60s, 70s, 80s when external beam radiotherapy was available, but it was incredibly disfiguring. If you give external beam radiotherapy to the eyes and the orbits in a child, their midface doesn't develop. They have poor vision, and they have, you can tell that they've had radiotherapy for their whole lives. There's second tumours within the radiation field down the track. So it was no longer as life-threatening, but it significantly disfiguring. And then since we've had success with initially systemic chemo, and then more recently certain centres use actually chemotherapy directly into the ophthalmic artery by a radiation interventional radiologist. The more ocular morbidity is significantly reduced. So it's become a tumour that was almost universally led to death, to almost everyone survives, and now often people survive with good function. But the survival rate in low-income countries is a lot lower than it is here. And the smaller the tumour is when we start treatment, the more likely that we can conserve the eye and save vision. We have a child that we're caring for currently at the Children's who has a known family history of retinoblastoma and was, I think, 1 week old when had the first examination under anaesthesia. The next one found a tumour which was just above the area that does the central vision on an OCT scan, so just on an imaging scan. Couldn't see it when we looked in, but was detected just with the imaging technology, able to apply laser to it, and progressively as children get older, the tumours go further and further out from the centre, and this patient develops a number of other tumours, but none of them threatening the vision, and almost certainly will maintain excellent vision for her whole life, whereas her mother was detected was a new diagnosis and had a nucleation. So there's in one eye and very poor vision in the other eye because of advanced disease. So it's polar opposites. So this child will have a completely normal life, completely normal visual function. So the earlier we can detect them, the better. And I suppose, and this I think is what I'm getting at with that this was a tumour. This wasn't taken from our patient, but essentially that's what we're looking at. You can't see, the top picture is what it looks like, and about where my pointer is where the tumour is. Can't see anything, but we do a scan and can find it and apply laser to that, and it works very well. The question of, it's been looked at how good our referral pathways are overseas, and essentially general practitioners are very, very good. And this was done by a man that I trained with, the consultant I trained with in the UK, is one of the things that he's particularly interested in. And the time from symptom onset to parents visiting a GP is often about a month, but from a GP to see an eye doctor is on average 7 days. So it's a bit longer than after going to the emergency department, but perhaps, you know, the GP is the one who sends the patient to the emergency department. A bit longer than an optometrist, but an optometrist is very highly trained in eye conditions. So that all makes sense. I think 7 days is pretty good. This is the genetics of retinoblastoma. The reason I think it's worth talking about is, again, it's just if you have a patient who has retinoblastoma, the thing that needs to be coming, you know, the alarm bell that comes in your mind if you see someone of childbearing age, or not only female, a man who might be about to embark on having a family. You need to be thinking, could this be familial? Because we want to find that patient that I've just described who has who would detect the tumor when they're 5 weeks old or whatever it was, and start treatment and are able to save their vision. So that's for family planning. And this is just the summary. So in terms of the tumors, you either have, if you have about 60% of tumors that we see somatic, so it's two mutations in the one cell in the eyelids, the tumor, and the rest are either germline or mosaic, which is just that it's in some mosaic, some cells in the body, and germline, it's in all the cells in the body. The issue with germline is obviously the family planning one that we talked about, but the other issue is they're at higher risk of second tumors, skin cancers, sarcomas, pinealoblastoma. So worth just knowing that if you have a person with retinoblastoma, I think it should just be an alarm bell. You need to just check, is this, have you, have you been in a retinoblastoma service? What's the genetic nature of your tumor? And where can you get information about that? Because if it's somatic, all these points in number 2 don't matter. There's if it's definitely somatic, there's no risk to siblings or offspring. And in terms of finding out information from anyone in Victoria, we have it's a small team who does retinoblastoma here. I'm one of them. The 2 ophthalmologists who've been doing it for 30 years are James Elder and John McKenzie, and Anu Matthew and myself are coming on now, and have been doing it for Anu for the last few years, and I've just come back and been doing it for about 15 months here with the team. And we're the people you can reach out to. There's also a retinoblastoma care coordinator, who, if anyone in Victoria has had retinoblastoma, they'll know who she is. She's been doing it for about 30 years as well. For these sort of patients, they're rare. If you have any question, I think feel free to approach either Sandra, who's the care coordinator, or I'm very happy to be contacted directly. So that's RB. Uveal melanoma, which is the most common one in adults that we see, is these are my take-home messages for GPs. Vast majority of lots of our patients will have their staging surveillance organised by you. The liver is the most common site of metastatic disease. And as I said, there's this new treatment called tebentafusp, which is coming online, which is treatment of metastatic disease. But there are also a number of other agents that are being investigated. So hopefully, unlike cutaneous melanoma, which has completely been transformed over the past 10 years in the management of metastatic disease, that's not the case for uveal melanoma, but hopefully it will be in the coming years. Summary of uveal melanoma. So it affects the uvea is that middle layer of the eye. It's the iris, the choroid, and the ciliary body. So iris, ciliary body, choroid going backwards. So the coats of the eye, the sclera, the white bit, the choroid, and then the retina, looking at the back of the eye. Even despite excellent local control, so our local control with either, well, if you nucleate the eye, the local control is 100%, but with radiotherapy, which is treatment of choice in about 60 to 70% of patients with uveal melanoma, and even with excellent local control, still about 50% of our patients will die from metastatic disease at the moment. So it's a devastating diagnosis, and the treatment of metastatic disease is hopefully going to be something that improves. The way we figure out what the chance of it spreading, basically how big the tumour is. If the patients are, if they're older patients tend to have a higher metastatic rate, and then the genetic abnormalities in the tumours. There are less genetic abnormalities in these tumours than other ones, and that's part of the reason why they're difficult to target with immunotherapy. So I suppose the reason to be thinking about this is that you should have from us, when we ask you to do a surveillance or staging, it's good to get an idea about what the chances are, what we think the chances are of this spreading. So if you've got sorry about the typo there, but basically it can range hugely from, so a patient who has a small tumor, so less than 10 millimeters in basal diameter, a favorable genetic makeup, which is disomy 3, and then less than 81, they've got a less than 1% chance of metastatic disease in 5 years. So there's a good question as to whether we should be doing a surveillance program at all, staging a surveillance at all. But if you compare that to a patient with a large tumor with more than 18 millimeters, with a negative genetic makeup, so monosomy 3, and that should be more than 81 years old, the risk is 70% at 5 years. So I think this is something that we're working on now, about having some guidelines. There aren't any guidelines in Australia about who or for how or how long to stage and have a surveillance program. This is something we're going to work on over the next couple of years, and hopefully we'll be able to give more guidance. In general, the place that it metastasizes is the liver, and if you're to screen, or if you're to surveil for 5 years, you pick up about 85% of tumours that spread. So I think that's a reasonable cutoff, 5 years, but it's not this isn't one that's been agreed upon by the medical oncology and the ocular oncology community, but that's something I think is reasonable. I'm not in the UK. The guidelines are that you continue lifelong. I think that's probably overkill, particularly if you have someone who's got a very favourable tumour. So I can't give you any hard and fast things other than to say that liver imaging, abdominal ultrasound, CT or MRI of the liver imaging is the best way to detect this. PET's not very good. LFTs are not very good. So some form of imaging, and probably every 6 months is reasonable for surveillance, and probably for 5 years. I'm sorry to be so non-specific, but as I say, hopefully in the not too distant future, we'll be able to give you a document which has been agreed upon, where we stratify people into low, medium, and high risk, and that there's a different algorithm for them. And that will be the reason I think it's not been the focus of a huge amount of attention, is that until very recently, there hasn't been a treatment for metastatic disease that worked. So detecting it early didn't. Well, there's no survival benefit for the patients. So, but as that changes, this will become much more important. This is just so you can see the type of things that I see at the back of the eye, what a melanoma looks like. This is a photograph of the left eye, and so this is the disc. The macula is in between these vessels going out to the periphery at the edges, and that shouldn't be there. That's a dark pigmented lump, which is a melanoma. They're different to cutaneous melanomas. They do not share any of the same genetic mutations. They're on the GNAC and GNA11 spectrum, which is very different to the cutaneous ones. And so sunlight exposure is not a risk factor for uveal melanoma. It can be for iris, but not for ones that are behind the iris. So there's this lump at the back of the eye. It has it's pumping. This is an OCT scan that's pumping out fluid. This is the lump there, and it has these features, these white dots, which are called lipofuscin. So that's just so you can see the type of thing what it looks like. And this patient, you know, the treatment options for these patients really are either enucleation or they are radiotherapy. In terms of radiotherapy, there's either external beam radiotherapy, or we can do a surgery, which is this surgery where we stitch a radioactive plaque onto the outside wall of the eye, so we deliver the radiation source directly to where that tumor is. The tumor that I showed you previously wouldn't really be amenable to that because it's surrounded the optic nerve, and we couldn't be assured of tumor control. Anyway, so this is what an eye looks like in surgery. We've marked out where the tumor is after identifying it, probably by shining a light in the eye, and then this is a dummy plaque, so a clear plastic plaque that goes on. We then check the position of the plaque to make sure it's overlying the tumor, and then this is the radioactive plaque. So that you have a feeling for the types of treatment we do, it's either enucleation or it is radiotherapy. To say about 60% have radiotherapy in the form of this surgical one. I've talked about most of these things, and so this will be there for your reference. At baseline, sort of staging, I think looking at the chest is a good idea because it can involve the lungs rarely, but that obviously your investigations as you do for staging will depend on your history and clinical examination. So if there's anything to suggest something else, then your investigations would be directed by that. Almost none have metastatic disease that is detectable at the time of diagnosis, but 50% of people end up dying from this. So the tumor has spread by this point. It just takes a number of years to become detectable. And this is just some, as I say, some broad recommendations. Abdominal ultrasound is very good. CT abdomen, we were discussing with radiation oncologists and oncologists recently, and they'd often recommend a CT if it's a high risk, a CT that's low risk from the radiation, and it's perhaps the best way to detect it, and they think even better than an MRI, and it's more widely available. But if you've got a lower risk tumor, an abdominal ultrasound is very reasonable. So Alfred Health Medical Oncology is Mark Shackleton, and Peter Mack is Damien Key, who have particular interests, but I'm sure your local oncologists as well can help. Then I've talked about this. It's this tebentafusp that is the agent that is showing a increase in 1 year survival, but as you can see, it's not a this is fantastic, but we're looking for agents that are going to change this like they have in cutaneous melanoma. And then I'll just talk briefly.
Sorry, Rod, just interrupt you. I've got one question, but also I'll just let you know you've got 10 minutes left.
Fantastic.
There's a question about uveal melanoma. What are the symptoms? I mean, how are we picking these up?
Most are actually picked up incidentally. So it's very good for patients to have a dilated examination over the age of about 50. It's much more common in elderly people. So over the age of 50, an annual eye check or biannual eye check with an optometrist for a dilated examination. So that's the most common way. It's just incidentally. The other symptoms are photopsia, so flashing lights or decreased vision.
Great, thanks.
Quickly on these, I've just got a couple of slides on these new agents. So pretty much all anti-cancer therapies will cause dry eye and sore eye. So if you have that's the most common thing, and that can be treated with lubricating eye drops. But these newer ones have a couple of just ones to know about. So if you have these new agents, the checkpoint inhibitors, they cause uveitis and quite severe uveitis. And so they have not just a sore, irritated eye, they also have light sensitivity, decreased vision, floaters, and rarely will require cessation therapy. So if you have someone who's on a checkpoint inhibitor, just to know that uveitis or inflammation inside the eye is one of the complications and the common symptoms. And they're different to dry eye. Dry eye, the patients will tell you that the eyes are burning, they're itchy, they're watering, and if you put some fluorescein in, there'll be an increased uptake. And then this is well, mainly for my interest, but also I suppose reasonable to know because MEK inhibitors are used quite frequently in cutaneous melanoma, and they can have a very rare retinal complication where they have retinal detachment, so serious retinal detachment. So again, if you have a patient on a MEK inhibitor and they have reduced vision, then worth seeing an ophthalmologist. And so when not to refer someone who's on systemic cancer agent would be if you're pretty convinced that, so if it's, I suppose, if it's not a MEK inhibitor and it's not a checkpoint inhibitor, I think it's reasonable, and they just have symptoms that sound like dry eye, I think reasonable to treat it as that. But reduced vision and photophobia and significant pain are the red flags. Any questions?
Sorry, just unmuting myself. I think, what are MEK agents is someone's asked you. So
MEK inhibitors they're often used with the BRAF inhibitors for cutaneous melanoma. I think they're now first line, and I'd have to look up a couple of examples of what their names are. I'm dreadful with drug names, but I think they are, if you have a BRAF mutation, it's either that the patients with metastatic cutaneous melanoma, my understanding is they're either treated with immunotherapy or checkpoint inhibitors such as nivolumab and ipilimumab, or with, if they have a BRAF mutation, then they have a combination BRAF inhibitor and MEK inhibitor. And I think that's the combination that means they're less likely to have relapses, but it's sort of a bit out of my wheelhouse.
Thanks. I don't think we've got any further questions at the moment, certainly none that I can see. You've answered both of those. Awesome. Well, thank you. That's a really interesting presentation and something that we don't normally get. And as you say, I know that they're rare, but there's lots of important things that we need to know as GPs.
Absolutely.
Yeah, I might move on to the next talk unless you had any final words that you wanted to say.
No, none.
Okay.
Thanks for having me.
Awesome. Thank you so much for your time and your expertise. Really appreciate it. Okay, so I might get Madeline to switch back to my screen for a moment. Thanks. Seriously. Okay, show my screen. Okay, so Dr. Jwu Jin Khong is a Fellow of the Royal Australian and New Zealand College of Ophthalmologists, appointed at the Royal Victorian Eye Hospital and the Austin Hospital. Dr. Khong graduated from the University of Melbourne with honours in a Bachelor of Medicine and Surgery in 2001, and she underwent general ophthalmology training in Adelaide, followed by subspecialty training in orbital plastics and lacrimal surgery at the Royal Victorian Eye Hospital in 2011. She undertook a further international orbital fellowship in Academic Medical Centre in Amsterdam in 2017. Her academic interest in thyroid eye disease leads to a PhD degree in the genetic study of thyroid eye disease in 2018, supported through the Australian Postgraduate Award. Dr. Khong is a clinical supervisor for the Victorian Eye Registrar Training Program and leads the ophthalmology teaching program for Doctor of Medicine at the Austin Medical School. So Madeline, I'll get you to change to Dr. Khong's screen. Thank you.
Well, I hope it is sure. I'll share my webcam. Hello, everyone. I hope the slides are coming up. I'll just start from the start.
Yeah, I
first
can see them.
thank you. Yeah, thanks, Lena, for the introduction and for invitation to speak at this GP educational program at the start of the year. And I would also like to thank all the participants for gathering here tonight for your time. And hopefully I have met some of you through the letter of correspondences we have sent to each other. I would like to pay respect to the Wurundjeri's elders past, present, and future for our auspicious gathering here tonight. So tonight we'll be covering some aspects of assessments of lumps and bumps of the eyelid and managing the benign and malignant eyelid lesion. The second topics of tonight's education sessions will be understanding the common eyelid conditions, including eyelid malpositions, droopy eyelid, and how we restore the eyelid function. And through this process, identifying some red flags and urgent cases for a referral for urgent assessment. We will lastly review the primary care referral guidelines for the oculoplastic conditions. I'm just going to move this screen a little bit so that I can see my whole slide. Okay, that's better. Now, patients with eyelid lesions often present through the primary care doctors. Most of these eyelid lesions are benign, such as cyst, chalazion, nevus, and papilloma. It's important to know some of the clinical key features to distinguish them from the less common malignant eyelid lesions. Now, when it comes to eyelid lesion, the first thing that comes to my mind is understanding the anatomy of the eyelid. It's made up of the anterior layer, which is made up of skin and orbicularis, and with it comes the hair follicles and the gland of Zeiss and gland of Mohs, which are the sebaceous and sweat glands respectively. The posterior lamella is made up of a firm tarsus, and lining at the back of it is a conjunctiva. Running in the tarsus is a meibomian gland that secretes part of the tears component. One of the most common acute eyelid lump is an external hordeolum, or stye, more commonly known as. It is an acute infection within the eyelash follicle and the associated glands. It tends to present as a tender lump that is pointed and yellow based at the hair follicles. It is a self-limiting condition that tends to get better after about 3 to 5 days with warm compresses alone. However, if the abscess within the hair follicles did not discharge with warm compresses and it spreads into the preseptal tissue as cellulitis, then the course of oral antibiotics like Caflex should cover it well. Then the other common acute eyelid lump is the internal hordeolum. The internal hordeolum is an acute infection and inflammation of the meibomian gland. Because they are deep within the tarsus, the lumps tend to have a less distinctive margin, red and inflamed focally. Now, the first line treatment for this is actually warm compresses to try to discharge the blocked meibomian gland. And it may take up to a couple of weeks for the inflammations to settle. For example, in this case, it doesn't necessarily need an oral antibiotic straight away. You could consider putting topical antibiotics drops in addition to warm compresses as the initial treatment, and review again in a week to see how the patient progresses. Now, there is a Cochrane review that looks at what are the evidence for using topical steroid and topical antibiotics, but there was no real trials that prove the efficacy of this additional treatment. Therefore, we need to, based on our clinical judgment of what we would do for this patient. For example, this patient also has an acute internal hordeolum, and the severity is much more, where there is increased erythema and spreading of infections to the upper eyelid. In this case, it clearly needs oral antibiotics and even lancing of the abscess to discharge to hasten the recovery. In comparison, chalazion, which is a chronic granulomatous inflammation due to obstruction of the meibomian gland, there is no role of using oral antibiotics or topical steroids here. The natural history of this is a chalazion will resolve spontaneously in a quarter of the patient over a period of 2 to 3 months. Hot compresses, in addition, will improve the resolution rate to about 40 to 50%. At the end of the 2 to 3 months, if the chalazion does not resolve and it is big and persistent, then incisions and curettage has a good role in resolving the chalazion, so as intralesional steroid injection. There is a small chalazion treatment trials done in about 2007 that involved 150 patients, where an arm of them was subjected to just hot compresses, an arm was subjected to triamcinolone injection, and the third arm is incision and curettage. If you look at this data, 50% of the patients have resolution of their chalazion with hot compresses alone, and that increases to 85 to 90% with incision and curettage and triamcinolone. The other benign lesions are cysts. Cysts along the eyelid are commonly cysts of mole or cysts of Zeiss. A cyst of mole has a translucent appearance. They tend to be around the eyelid margin, and particularly for cysts of mole, it likes to be around the punctum. If the lesion is small, it could be left as it is. If the lesion is big and unsightly, then it will require removal of the whole cyst lining to resolve the cyst of mole. If it's just being punctured by a needle, the cyst will recur readily. And it's probably best done with an eye specialist, because we tend to protect the punctum and the canaliculus when I remove a cyst of mole like this in this case. A cyst of Zeiss, on the other hand, arises up from a sebaceous gland, and therefore the appearance is quite opaque and yellow like this. And again, they are completely benign. The third most common eyelid cyst is an epidermal inclusion cyst. For some reason, either by trauma or rubbing or spontaneously, a bit of epidermis from the skin gone under the skin and form a cystic lesion that is filled with keratin. They tend to be firm and feel mobile on touching them. A squamous papilloma is more commonly known as skin tag, and the removal of them is usually purely cosmetic, like in this one. Seborrheic keratosis is also another common benign lesion on the eyelid. They have a stuck-on appearance, a warty appearance, and sometimes they can appear friable like this, embedded among the eyelashes, but not destroying eyelashes. Nevus, on the other hand, are mostly pigmented, and that can just gradually increase in the numbers as the patients get older. In this patient, she has multiple nevus. On the right eye, at the eyelid junction, she has a junctional nevus, which is nice and flat. She also has a a blue nevus or a compound nevus on the left lower eyelid that is quite focal and small. Nevus can be amelanotic, like this lesion here. It is different from, say, a basal cell carcinoma because it is very bland in its appearance. There is no telangiectasia along the eyelid. But to get the most definite diagnosis, you need to do an excisional biopsy to prove it. Cases that is suspicious of an eyelid malignancy usually has some risk factors, such as they have a history of skin cancers in the head and neck region, they have a history of excessive sun exposure in their work and their lifestyle, and they previously might have head and neck radiation or is on immunosuppressant for organ transplantation. When you look at the lesion, there is a period of growth, and there is loss of eyelashes to suggest local destruction caused by a tumor. There may be ulceration, and the eyelid feels indurated where the lesion is. In more advanced cases, it can lead to distortion of the eyelid margin. Telangiectasia is a common feature of eyelid malignancy. I'm going to show you a few pictures now to differentiate between the different periocular skin cancer. Basal cell carcinoma is the most common eyelid malignancy. It accounts for about 90% of the eyelid skin cancer. They typically appears in the lower eyelid or at the medial canthus. They're slow growing and is locally destructive. The most common BCC subtypes that we see is a nodular BCC, like the picture on the left here. And over here, we have a pigmented BCC that tends to be more common in Asian patients. This is a BCC that has been left untreated for a number of years. So it basically has formed a rodent ulcer, where you can see central ulceration and the raised pearly margins with distortion and irregularity of the eyelid margin. I'm going to show you another case now. This is a BCC involving the cheek, and you can see telangiectasia, raised pearly margin and areas of ulceration and distortion of the skin. By the way, the top eyelid lesions here is a proven biopsy as a seborrheic keratosis, which is benign on the upper eyelid. This patient here has what we call a morphic or sclerosing BCC. The signature of it is it's got this rope-like extension, like a linear rope-like extension, and the margin of it is hipped, indurated, and has a pearly appearance. In this case, it causes a cicatricial or scarring-related pulling of the lower eyelid, causing an ectropion on the eyelid. This gentleman here has an infiltrative BCC that is really quite difficult to see apart from a few spots of ulceration along the eyelid margin. Now, squamous cell carcinoma only accounts for 5% of eyelid tumor, but they are more aggressive and they have a propensity to spread, usually via the nerve and less commonly via the lymphatics and with hematogenous extension that typically arises from solar keratosis and Bowen's disease, which is SCC in situ. The patients might have a history of radiation, and they are more commonly in the immunosuppressed individuals on long-term immunosuppressant. SCC of the eyelid tends to bleed and ulcerate early on, like in this case. They tend to form keratotic plaques with hyperkeratosis. They tend to form scaly erythematous patches on the eyelid. And in this case, it's a combination of these factors where there is actinic changes, there is some ulceration, hyperkeratosis of the eyelid. So these are suspicious features of a squamous cell cancer. Eyelid melanoma, on the other hand, is quite uncommon. It only accounts for a % of the eyelid malignancy. For the eyelid, it tends to be the superficial spreading type, which is equivalent to SCC in situ, full thickness melanocytes infiltration. The second most common subtype is lentigo maligna, where there is abnormal melanocytes in any layers of the epidermis. Just a summary of the ABCDE of melanoma. The lesions will appear pigmented, usually pigmented, with asymmetry. The borders will look irregular, the colors is uneven, and the diameter is usually greater than 6 millimeter, and it grows over time. So some of the pictures here, this is a gentleman who has lentigo maligna. This gentleman has melanoma arising from lentigo maligna. This picture here is a pigmented nodular melanoma. You could argue that it looks actually like a pigmented BCC. So the only way you'll find out is with the biopsy. And this picture here shows a melanotic melanoma, which look exactly like a BCC. Sebaceous cell carcinoma, I will touch briefly about this. It is uncommon. It tends to be in elderly female patients and arise from the glands of Zeiss or the Meibomian gland. It can present as a lid mass. It can present as a recurrent chalazion or unilateral blepharoconjunctivitis. Just one thing that's important to note is that there is an association between sebaceous cell carcinoma with bowel cancer, immunotory syndrome. So with anyone that I have diagnosed with sebaceous cell carcinoma, the next question I have is, do they have a history of bowel cancer, and they will require genetic testing for it. It's part of the DNA mismatch genes problem. Now, come to this point, I have a story to tell. This is a story of our patient during the COVID lockdown period last year. This lady has had 2 years history of feeling discomfort and foreign body sensation in the eye that was treated all along as blepharitis. And really, when you have a look at her, there was really nothing much to see. She has got some redness and what looks like obstructions and yellow changes at the eyelid margin. A clever doctor everted her eyelid and finds that the conjunctival lining looks a bit abnormal and took a biopsy. And in that, it shows some abnormal cells that is consistent with sebaceous cell carcinoma. So she came to us and we excised focally on the wedge excision for her. And for sebaceous cell carcinoma, we will treat it with intraoperative margin control. In her case, she has serial paraffin margin control. So she has a paraffin section and she came back the next day with a defect like this. The pathology shows that all the margins are still involved. So she has further excisions, and this is how she looked like. And the overnight paraffin shows that she still has residual disease at the medial conjunctiva and lateral skin. Therefore, she ended up with a final defect of the whole upper eyelid, just from that little changes on the eyelid over a 2 years period. Eventually, she had complex reconstruction of the upper eyelid that requires tarsal grafting, obtaining from the other eye, a buckle-handed graft, a buckle-handed flap, and a skin graft to repair her eyelid. So the moral of the story is, if a patient has non-resolving chalazion, recurrent chalazion, especially in the elderly female, or unilateral blepharitis that does not resolve, sebaceous cell carcinoma is rare, but is real. So when you send a patient to us for management of tumor, we will do a number of things as below. We would confirm the diagnosis with a punch biopsy. We would then do surgical planning depending on what the diagnosis is, and that usually involves wide local excision with intraoperative margin control to enhance the rate of complete clearance. And we would do eyelid reconstruction depending on the site and size of the eyelid defect. Post-operatively, the patients would have periocular tumor surveillance 6 monthly for at least 2 years and yearly for about 5 years. A quick one on eyelid melanoma: if the initial biopsy has a thickness, has a Breslow thickness more than 1 millimeter, I would refer them to a melanoma unit to consider for sentinel lymph nodes biopsy. For the sebaceous cell carcinoma, patients, their surgical specimen of tumor will undergo genetic testing looking for Muir-Torre syndrome. Yep, as we mentioned before. So now I'm going to show you some examples of eyelid cancer excision and reconstruction. This gentleman that has the indistinctive BCC of the eyelid that was proven on biopsy, I have referred him to dermatologists for most micrographic surgery excision, because that will give him the highest chance of clearing the tumor and preserving normal eyelid tissue. That's the purpose of Mohs surgery. In his case, after he has Mohs, he had basically most of the lower eyelid being excised and part of the upper eyelid was involved from what looks like an inconspicuous BCC. He underwent a repair with tarsal sharing procedure, lateral advancing flap to the upper eyelid and the skin graft to the lower eyelid to repair the 2 layers of the eyelid. 2 weeks later, he had reopening of the eyelid to give him a functioning and cosmetically acceptable result. In another case where the BCC is involving the medial canthus and lower eyelid, she underwent an intraoperative frozen section to obtain tumor clearance. At the end of the surgery, she had most of the lower eyelid and the medial canthus being removed. To repair this eyelid defect, we have used a forehead glabellar flap to replace the tissue loss in the medial canthus, tarsal sharing procedure from the upper eyelid implanting to the lower eyelid, and a transpositional flap. And this is how she looks like about 2 weeks following the surgery. Consideration for adjuvant radiotherapy is given for squamous cell carcinoma, usually if the size is more than 2 centimeters and the lesion is poorly differentiated and there is any evidence of perineural invasion or lymphovascular invasion on the histopathology. So the patient will then be referred from us here, usually to Peter McCallum for consideration of radiotherapy. Now, just quickly touching on medical treatment for skin cancer. Radiotherapy could be considered for skin cancer management as an alternative to surgical excision in patients unfit for surgery or who refuse surgery for any other reasons. But it is in my opinion, it is a poorer alternative compared to surgery as the primary management, because you can really not monitor the recurrence of tumor easily. Imiquimod Aldara cream has been TGA approved for the use in superficial BCC. Now, the important point is this is for superficial BCC and it's not for nodular BCC or for an infiltrative morphic BCC. Its success rate is about 80% as compared to 90–95% clearance with surgery. Epudex has been approved for the use in Bowen's disease or actinic and actinic keratosis. Used for about 4 to 8 weeks, it has a resolution rate about 80–90%, which is quite high. But there is contraindication of use in around the eye region in case it gets into the eye. Now, let's move on to eyelid malposition. Ectropion of the eyelid is quite common. The outturning of the eyelid is usually due to involutional changes of the eyelid with increased eyelid laxity. Other causes of ectropions include cicatrizing changes, commonly due to sun damages on the face, actinic changes of the face, like this. Uncommonly, I've seen a patient who has bilateral lower eyelid cicatricial changes due to a rare systemic skin condition, ichthyosis. The patient presented with lower eyelid ectropion, plus there was skin fissuring and thickening. If you look at the fingers, there is nail involvement, and the whole body has got these scaly, plaque-like changes on the skin. So I thought that was an unusual and interesting cause of cicatrizing changes. The eyelid can also develop paralysis from facial nerve palsy, and in the elderly patient who already have laxity of the eyelid, that can lead to a paralytic ectropion. The presentation of an ectropion is usually watering of the eye, a foreign body sensation, and red eye. Not so much of pain, interestingly. And the principle of ectropion repair is that, well, they tend to be able to improve with surgical repair and not medical treatment. The principle of surgical repair is to restore the original anatomical position, which involve eyelid tightening, reposition of the punctum, and in this case, with a tarsal ectropion, repair of the inferior retractor, which is a muscle band that controls the vertical stability of the eyelid. In cases where there is shortage of skin, like in this lady with cicatricial ectropion, they will need skin grafting to the lower eyelid to lengthen the anterior lamella. Eyelid entropion, on the other hand, is less common than ectropion. The eyelid turns in, and as a result of that, the eyelashes is rubbing against the globe. It tends to present with more painful sensation, foreign body sensation, and watering, and some cases can get corneal abrasion from it. So it tends to manage it more quickly than the ectropion patient. Most of the cases are involutional changes. This is a diagram of how the lower eyelid is and the relationships of the tarsal plate with the inferior retractor muscles. When this muscle is relaxed and lax, the overriding of the orbicularis push the tarsal backwards against the cornea. Therefore, the surgical repair of it, importantly, will involve inferior retractor repair and incisions that will prevent overriding of the orbicularis and tightening of the eyelid. One telltale signs that the patient has entropion is that you look at them from your examination chair and they have this roll of skin at the eyelid margin and the eyelashes are not really visible. Following surgery, you can see that the patient's eyelashes has nicely turned out and she lost that roll of orbicularis at the eyelid margin. Dermatochalasis is redundancy of the upper eyelid skin. We tend to treat them at the eye and ear hospital when they start to have effect on vision. The medical criteria for managing dermatochalasis is, firstly, they need to have lateral hooding, at least overlapping the eyelid margin. And secondly, they show some visual field defect that tends to be located superiorly and temporary. So the aim that we try to achieve with blepharoplasty here is to adequately remove just enough excess upper eyelid skin to achieve symmetry. And in some of my cases, if they have a brow ptosis component that is mild, I would do an internal brow palsy as required to elevate the brow to help with the overall symmetry. Eyelid ptosis, on the other hand, is the lowering of the upper eyelid heights, where the eyelid margin is encroaching on the pupil. The causes are mostly involutional, like in this lady, and we repair it with levator aponeurosis repair. Some cases are neurological, such as myasthenia gravis and Horner syndrome. Congenital ptosis in children needs to be referred more urgently because there is a risk of developing lazy eye or amblyopia due to covering of the visual axis. Sometimes, a few times in a year, we will see traumatic ptosis from either a tree branch hitting on the eye or some object sitting on the eye, and mechanical ptosis usually related to tumor. So eyelid ptosis. If you look at the patients with ptosis, remember to look at their pupil. If the pupil is small, think about Horner syndrome, and they will require urgent referral to rule out a pancreas tumor, lung tumor, and to rule out carotid dissection. These carotid dissection cases will present with pain or a history of having trauma to the side of the neck. Third nerve palsy ptosis tends to have double vision, where the patient's eye is turning out and down, and the pupil is dilated. The parasympathetic fibers are involved early on in brain aneurysm because it tends to run on the outside of the third cranial nerve. So they will require urgent referral for workup. So in summary, we treat patients with blepharospasm. We accept referral for blepharospasm for Botox treatment, blepharitis that is severe and persistent, ectropion and entropion for repair. We tend to prioritize the entropion patients, and dermatochalasis that is affecting sight of an obstructing line of vision. Ptosis, involutional ptosis are treated routinely. Children's or ptosis related to neurological causes are usually triaged more urgently. Non-resolving chalazion we will see, and as well as any lesion suspected as a malignancy. We also manage patients with poor fitting prostheses or prostheses with mucus discharge. For any patients that presented with orbital symptoms like acute proptosis, pain in eye movement, and they're suspicious of orbital masses, we would refer them, we would ask you to refer them to ED. And patients with acute infection in the periorbital region will also require referral immediately to the emergency. Okay, so I will take any questions now.
Okay, JJ. So all the audience are muted, so I've asked them to write questions in the question box, and a few have come in, so I'll read them out, and then I've got a couple of questions of my own.
Yeah.
So ectropion you've talked about, but should suspicious eyelid lesions be referred to a general ophthalmologist or to a specifically an oculoplastic surgeon?
Okay, well, it partly depends on how big the lesion is. I would suggest, I mean, my personal preference would be that they be referred to an oculoplastic surgeon, because often we would receive referral from the general ophthalmologist if they think that the lesion is too large to be excised and to be closed primarily. So it depends on how big the lesion is, whether there is enough eyelid laxity to close the eyelid. Everyone has different threshold of what level of comfort they are in closing the eyelid.
Yeah. So if it looks really, really simple, maybe general ophthalmology, but anything other than that or anything of a decent size really needs to go to an oculoplastic unit.
It's anything involve more than a third of the eyelid, I think an oculoplastic surgeon. Yeah.
Yeah. We have another question. If ectropion is left untreated, would the cornea be affected?
Ectropion, if left untreated? Is it ectropion? Just wanting to check.
Yeah, ectropion, yes.
Yeah, ectropion, if left untreated for a long time, can cause dry eyes. It can cause inferior keratopathy in some patients. It partly depends on how good the patient's Bell reflex is and how good they are in terms of their blink reflexes. Some patients, they would have ectropion for years, but the show is mainly on the sclera, and therefore it doesn't affect their cornea much. But there are some patients who are very sensitive to any malpositioning of their eyelid, such that when we do fluorescein staining, the corneas are involved. So for the ectropion patient, it will be good to put some fluorescein in the eye and check how the cornea is looking. The very first step, temporizing measures, would be to give patients lubricating eye drop, such that they don't develop exposure keratopathy. Yeah, that will be my suggestion.
Yeah, great. And is bilateral ptosis a congenital condition?
Bilateral ptosis in an adult, gradual development of bilateral ptosis is usually due to involutional ptosis, usually with the lengthening and dehiscence of levator aponeurosis. That's the most common that we see. Bilateral ptosis in an adult can also be neurological, less commonly, such as that we see in myotonic dystrophy patients. We would also see that in patients who has CPEO, which is a mitochondrial disease. In those situations, the levator function is weak. Patients have weak muscles, and they also have inability to look up. So there are some associated signs to suggest that they are not involutional.
Okay. And I did miss one question. What is the treatment of post-trachoma concretions in the eye, in the lids, eyelids?
Post-trachoma concretion, the common things that we see with trachoma is scarring of the conjunctival lining of the eye, such that the eyelid margin is turned inwards. And that is a form of cicatricial entropion. We don't tend to pick any concretions or any irregular conjunctival surface in the trachoma patient because there's already a scarred surface. So the eyes tend to be uncomfortable, scratchy, and irritable a lot of the time. So the baseline treatment, if the eyelashes are not touching the eye, is regular lubricating drops in that situation. When the eyelashes have turned in and touches on the cornea and has the potential to cause cornea scarring, we would do cicatricial ectropion repair that often involve splitting the top eyelid in half into the anterior and posterior lamella and everting the eyelashes anteriorly. And that will often work, and they may require repeated operations to do that in the future.
Okay. All right, I think that was all the audience's questions. A couple of people have put their hand up. I think if you want to ask a question, they need to type it into the question box for me, but I have some questions.
Yeah.
What did I write down? With chalazion, I was wondering who to refer to and where to refer, but I think you might have touched on that in the referral guidelines.
Yes, when the patient is referred for chalazion, they will probably come to a general ophthalmology clinic because any general ophthalmologist will deal with chalazion.
Yeah, I think you covered that. Really, there's no point referring them quickly. They won't be seen quickly, but most of them will resolve spontaneously or with the addition of warm compresses. So we only really need referral for those after a little bit of time.
Well, yes, this is a common scenario that I see in my private practices, in the sense that the patients will come to me at different timelines. Some patients with chalazions would come to me about 4 weeks to 6 weeks from the onset, from the initial onset, where they have tried warm compressors, they have tried a course of topical antibiotics and it's not settling. Firstly, I always tell the patient, we don't expect that it will completely go away in such a short period of time. And I often ask them to wait for another 6 weeks and try the hot compressors really well. And I will usually stop their topical or oral antibiotics if they are still on them at that time point. And I will then see them again at that 2 to 3 months timeline. If their chalazions are persistent and there was no signs that it is abating, I would there and then do an incision and curettage for the patient. That's my personal approach. And when a chalazion is incision and curettage doesn't resolve the lesions completely, and there is some induration and erythematous at where the chalazion is, my second line is an intralesional steroid injection. And that will also help to settle the chalazions a bit more. I choose that as my second line treatment because with any steroid particles around the periocular region, there is a small chance of embolism of that steroid particle into the blood vessels. So to me, the risk of that is slightly more than incision and curettage. But in safe hands, if you do withdrawal with your stringers, then that reduces the chance of that happening.
Great.
Yeah, so I answered that question.
I also was looking at those seborrheic keratoses on the eyelids and wondering if if you know, it's clearly to us a seborrheic keratosis, and we're very comfortable that there's no risk of it being something else or malignant, what should or could we do about it? I mean, would we be brave enough to try to treat that with something, especially if it's really cosmetically bothering the patient or potentially in their line of vision?
Okay. Well, treating a seborrheic keratosis is usually purely cosmetically driven. Or the other thing is that patients, all of us like to touch our eyes, and it's very easy, it's very conscious to felt something and pay attention to the area that we touch. So for a lesion that is sizable, it is reasonable to excise it because of its growth and because of its position, where it's interfering with the patient's lifestyle. They need to rub it all the time. So it's reasonable to do that. I would say that it is still good to send it to a person that often do eyelid excision, because you are looking at not losing too much eyelashes in the area, not causing distortion to the eyelid margin, and how you position that and close the wound has some certain effect on how the final outcome will look like. So for a small lesion, if the patient is not concerned, it can definitely be left alone as well. There's no hard and fast rule for these things.
Yeah. But you wouldn't recommend that we treated it with liquid nitrogen like we might to somewhere else because of the risks. Awesome. And I did have one other question. And you know, this is you probably have explained this in your talk, but can you potentially perhaps summarize what you think the key clues to differentiating between internal and external hordeolum and chalasia?
Well, yes, thank you. So in summary, an internal hordeolum may resolve and leads to a chalasia from the original obstruction. So the lump in that situation acutely tends to be red, rounded, and firm within the tarsus. Yeah. So I think an internal hordeolum will resolve, the initial swelling will resolve and leave a patient with that inactive, non-inflamed, non-infected chalasia. An external hordeolum is an acute swelling that is centered at the base of the eyelashes. So therefore, these lesions appear pointy, and it appears a bit yellow and pointy. And it tends to go away in about 1 or 2 weeks without leaving the chalasian lump. I hope that summarizes it.
Yep, great. Thank you. I think there's no further questions, and that's I think that's all of my questions done. So that was great. Thank you so much, JJ. You covered such a wide range of topics there, but all really useful things that we see all the time. Well, a lot of it that we see all the time. Perhaps the eyelid lesions, the cancers we don't see so much of, but is definitely something we need to be alert to and be referring appropriately. So I think that's a really awesome talk. Thank you so much. I might just get Madeline, if you had any final comments, JJ, sorry.
No, thank you.
That's great. I might get Madeline just to share my screen with everybody, just for my final comments. Thank you. Share my screen. Let's move everyone's questions out of the way. Okay, so evaluation forms will be emailed by Madeline from the Northwest Melbourne PHN pretty much at the close of this webinar. Attendance certificates will be sent out to, I think attendance certificates, not sure, but RSCGP points will be sorted out by the Northwest Melbourne PHN. If you're not already on my mailing list, please sign up for my emails at gpliaison@ioneer.org.au. PDF handouts will be emailed hopefully next week, and I will email my mailing list when the recording of this webinar is available. And just to let you know, we have our next webinar. We have actually changed the date if anyone did see this advertised on the Northwest Melbourne PHN's website. It's now going to be Tuesday, the 18th of May, 7 p.m. for 1 hour. And Dr. Lana Del Porto is going to cover common causes of visual loss in Australia throughout the lifespan. And thank you so much to our speakers, Rod O'Day and JJ Khong. Really excellent talks. Thank you, Madeline Leonard from Northwest Melbourne PHN, for supporting this and all of our education. And to the Collier Foundation, for their philanthropic grant that supports our education. I think that's me done. Thank you all the attendees for attending. We really value your support and attendance and your interest in learning about all things eye and ENT. And please complete your evaluation forms because we really do value your feedback. Thank you. I'll just check questions. I think that's it. Great, awesome. So I don't think there's any further questions. I think we can sign off now at 1 minute past 8. Awesome.